Okay, so I have to tell you something about the web technology and indication and beyond. So I will try to tell you all what you want to know about the web, but dare not ask. This is definitely something that very frequently we face. When we speak about the web, very frequently too, most of the people think that we are dealing with a Russian doll problem, which is basically, is the web indicated and efficient only when it fits with the aneurysm, like the Russian doll fit with each other? The answer is definitely no. Of course, when it fits, it's much more simple when you have such a regular aneurysm, which is perfectly theoretically speaking, fitting with a potential web because it has the same size. There is no real question, so you just deliver the web. And at the time, you obtain, as you can see here, a very good occlusion of the aneurysm after a 6-month control angiogram, including what you see when you look at the vaso-CT 6 months later. The web has not changed at all, and it fits perfectly with the sac of the aneurysm. The beauty of it is also you can check with a MR. There is zero artifact on the MR. So 18 months later, you can clearly see that there is no aneurysm, no neck remnant, and the patient is cured. Most of the time, we are using the Web 21 and the Web 17. Web 17 is definitely something that has completely changed the web treatment. And basically, it goes through a 17 catheter instead of the 21. Of course, this is a cartoon and it's a caricature, but it's basically to clearly tell you how easy it is to navigate with the Web 17, because it's like when you do a treatment with a coin. It has increased dramatically the navigability, the conformability. It is easy to resheet. You can attack aneurysms that are tight angle empowering. Mechanical assistance is also easy because you can put 2 catheters in the same guiding catheter. The 17 is not that big, so it allows the use of another catheter. There is no kickback effect because it's smooth, and the Web 17 is very smooth. So you really regain what I think is the sensation you had when you were doing coiling a long time ago. In addition to that, the new Web 17 is offering half size, which is something very interesting. Let me show you what is the sizing chart of the Web 17. You can clearly see that at this level, you have the possibility to have a 3.53 millimeter or a 4 millimeter web, which is very interesting. Even 0.5 millimeter of diameter is important. Why? If you look at mathematics or a web 3.2 millimeter, when you move from a 1.32 millimeter to a web 3.5 millimeter, the volume is moving from 14 millimeter cubic to 19 millimeter cubic. So when you increase the radius of 16%, you increase the volume of 36%, which is extremely important. So that's the reason why half a size is really important, because it allows you to fit perfectly with the aneurysm. With this kind of device, the very first choice for treating an aneurysm today is to use a web, unless it's too big aneurysm. Otherwise, bury aneurysm, the very first choice is using a web. This is a typical middle cerebral artery aneurysm, 6 millimeter aneurysm. It's easy to deliver a web. It's straightforward. The bifurcation is symmetrical, and you can put the web, detach it. This is 18 months later. You will see the compaction, and we speak about the compaction of the web later on. And if you look at the picture 18 months and 4 years later, it's exactly the same. It doesn't change at all. It means that this kind of concavity that you have at the base of the aneurysm is definitely belonging to the type of treatment you do with the web. We will speak later about this flattering and compression of the web. Another regular aneurysm, 5 millimeter aneurysm, which is treated with a web 4.5/3 millimeter. So we use very frequently this half size of the web because it allows you to fit perfectly with the size of the aneurysm. In addition to that, this aneurysm is pretty difficult to deal with because there is an acute angle when you attack from the parent artery, and the softness and the flexibility of this system is definitely giving you the possibility to attract acute angle, like you can see here. Look at the deformability and conformability of the system when it goes inside the sac of the aneurysm. This is the AP and this is the lateral. So if you see, there is a very strong deformation of the web after deployment, and this is a control angiogram immediate post-op and a year and a half after the treatment with a perfect closure of the aneurysm and no neck remnant. So despite this acute angle, it was easy to treat the aneurysm. Small aneurysm, even small aneurysm, 4 millimeter, 3 millimeter, are definitely perfectly suitable for web treatment. There is no question that this is our first choice. Look at this case. It has been treated in the same time, the 4.5 millimeter, 2 millimeter web and 3 millimeter, 2 millimeter in the other aneurysm. We are treating in the same session just by moving back one of the catheter to the other location. And this is the control angiogram 5 months later with a perfect closure of both aneurysm. And this is the same control angiogram 18 months later with perfect exclusion of all two aneurysms at the same time. So this is a 3D picture of the same patient. Now let's have a look at this aneurysm. Again, two aneurysms at the ACOM location, one a little bit bigger than the other. This one is a 2.5 millimeter, this one is 4.5 millimeter. The two ACOM aneurysms have been treated in the same session. This is not a big deal. Once you deal with the first larger aneurysm, you switch back the same catheter and you enter the second one. Look at those two webs, kissing web, located in the two aneurysms at the same time. Easy to perform, very quick to perform too, as far as you have the proper material to screen the web properly inside the sac of the aneurysm. And I mean by this, the possibility to do a vasocity or a dynacity to be sure that everything is perfectly fitting with the anatomy. So this is the control angiogram, which is performed post-op and 3 months later. Very good result, a little bit remnant at the neck of the aneurysm. But if you look at what's happening 15 months later, it's completely gone. So it means that there was an improvement of the result after 15 months of follow-up. Tiny little aneurysm like this one, which is 2.8 millimeter longer diameter, is treated by web very easily as a first choice. It's a 3 millimeter, 2 millimeter web that has been delivered inside the steady site. And again, look at the deformability and the conformability of the web. It's a very flexible material, which does conform if you do it very smoothly to the sac of the aneurysm itself, and gives that wonderful result. The shallow aneurysm, the aneurysm that has really no neck, the dome is exactly the same size as the neck itself, also are suitable for this kind of treatment with the web. So this is the web that has been delivered properly. It's a 6 by 3 millimeter web. And let's have a look at what's going on after 2 years follow-up. You have a very good healing. The proper sizing and the proper selection of the aneurysm is extremely important if you want to achieve a good result. Now, let's speak about compaction. Everybody is speaking about compaction and everybody is looking at what is the influence of the compaction regarding the anatomical result on a long-term basis. This is a personal statistics that has been done in the department. This paper has been published by Dr. Karoff recently in his journal, and you can clearly see that over an average follow-up of 12.5 months, 87% of the web compacted, if you check very carefully with a vasocity each time, and also if you have a 20% threshold. The average compaction for those aneurysms, those webs that are compacted, is about 50%. So everybody is saying that there is a big problem regarding this compaction with the web, but it's not. Now, let's have a look at the follow-up. If you look at the follow-up of the aneurysm and the follow-up of the anatomy and the anatomical result on a long-term basis, you can clearly see that at the level of 9 months, there is a complete rupture of the potential growth of this so-called concave aspect of the aneurysm due to the compaction of the web. So 9 months is the key where there is a modification of the slope towards more or less a plateau. So this is extremely important. Now, if you look at the proportion of this compaction effect between the web 17 and the other one, 120 web or other, there is no real differences between the two type of devices, 51% for the 17 and 43% for the other. So let's have a look to the result and the anatomical result and the complication. There is a study that has been published, which is something that gather 3 different studies that were performed in France, the French observatories, the webcast, and the webcast 2. And one can say that over a 50% distribution of MCA aneurysm, 21% of ACOM, basilar 17%, and carotid 10%. The unruptured aneurysm were almost the majority, 88%, 8% of ruptured aneurysm. The recanalization of aneurysm that have been treated with a web after coil treatment, for example, is only 3%, and the mean size of the aneurysm is 7.6 millimeters. So basically, we are properly dealing with berry aneurysm. Adjunctive device in this kind of series that were published, the trials, 12 cases over 163 cases were using an adjunctive device, stent or balloon or both. Complete occlusion was achieved in almost 53%, neck remnant in 26%, aneurysm remnant in 20%, which is basically what you get with the coil. So overall, the good result, which is adequate occlusion, is almost 80%. So this is what has been published in the trial. The very interesting thing is if you look at the same trials and the mortality, this is all the different morbidity and side effects that the patient were presented in this series. What you can see is a symptomatic transient embolic effect were only 3% of the cases, and the mortality was 0. Now, if you look at the long-term and the evolution of the MRS, this is what you can see here. So in summary, if you compare this result of the 3 studies that have been published in the literature compared to the HELP trial study and the CLARITY study, you can see that the side effect and then some neurological complication around 3% in the HELP trial and in the CLARITY trial. And in this, it was 1.3% death compared to 0% in the studies of the cases performed with the web. So there is no question that the complication, the morbidity, which is basically related to the thromboembolic complication, are about equal to what we face when we do coil treatment, and much better in terms of mortality. Now, this is a trial, and let's have a look at what is the real experience of our department, because it's also important. So we have 220 aneurysm treated with the web, 188 aneurysm have been followed specifically for a long-term basis. Adequate occlusion were obtained is 79.3%. Aneurysm recurrences in 20%. So basically, our personal experience is perfectly fitting with what has been published in the literature. Now, if you look at the aneurysm in which we have been using an adjunctive device, stent in 5%, web as a third choice in 72%, it's a very important parameter to choose properly. At the very first time, the web, you will see why. Double antiplatelets, and the web shape modification has been encountered in 37%. Retreatment is only less than 2%. So overall, we have in our personal experience exactly the same result as the one that have been published in the literature. Now, the morbidity and the mortality in our experience over these 220 and 188 aneurysm selected, the web morbidity is 6%, is 6 patients, And the web mortality is 2 patients, so less than 1%. So basically, it's an extremely good result in terms of mortality. Very interesting thing is what's going to happen in the evolution. Evolution is important just because, I'm sorry, I lost the full screen. Now it's full screen. If you look at the short-term and the middle-term effect, adequate occlusion, there is some regression of the occlusion on the middle-term effects. This is 4.5%. Now, if you look at the short, middle, and long-term, you can clearly see that there is no modification between the mid-term and the long-term in terms of treatment stability. Now, if you keep on going in a very long term, more than 2 years follow-up, exactly the same thing. There is no change between middle, very long, and long-term follow-up. So this is interesting. After 9 months, most of the time, you get a plateau and nothing is changing according to time. There are parameters that are also important in terms of prediction of the adequate occlusion. The most important one is definitely the web oversizing. We learn with time that oversizing the web is a key factor for good results on the long-term basis. And the web oversizing is extremely important if you look at this odds ratio in our statistic to predict the factor for adequate occlusion. Something which is not good for the long-term treatment and the long-term result is the regularity of the aneurysm and too much web shape modification, as you can see. Now, if you look at the factor for prediction of the thromboembolic event, this is why the very first choice of the web is important. If you take time and if you select properly the very first time the right size of the web, you limit dramatically the possibility of getting thromboembolic complication. As you can see here, this is statistically perfectly demonstrated. Now, let's have a look at the smaller aneurysm in our series. 29 aneurysms of less than 3 millimeters have been treated among these 128 aneurysms treated with web 17 and lower than 7 millimeters. The treatment is done with web SL and web SL 3.5 and 3. So the mean width is around 3 millimeters. 10, which is 40% of the 29 aneurysms were ruptured aneurysm. And if you look at the failure of treatment, 2 cases, because the web, even the 3 millimeter, 2 by 3 millimeter, it's too small, it's too big. So we could not do the treatment. And in one case, the angulation between the parent artery and the web was a little bit too tight, so we could not enter it. So a total of 26 tiny aneurysms was treated with the web 17. So let's have a look at this anatomical long-term follow-up. Mean follow-up, almost 12 months. Treatment success, 90%. Complete occlusion, 71%. Adequate occlusion, 90%. Mortality, 0. Transient deficit, 2. It's extremely safe. Even the tiny little ones are extremely safe to treat with the web. To finish, we can clearly say today that the web is efficient to prevent an early rebleeding in a ruptured aneurysm. All the statistics are clearly demonstrating that there is no risk of re-rupture after the web treatment compared to all what we know and the treatment we did before. So overall, it's an easy system to use. It's a quick treatment, specifically when you do the very first time the right choice for the web. It's very safe, and it's probably the safest treatment for berry aneurysm. No question if you compare the statistics. Long-term results depend on the anatomical selection for sure, but you can add adjunctive device if you want. And the web do apply for a lot of aneurysm, much more than expected at the very beginning. Thank you.